how can I maximize my work into doing more good? Nurse practitioners are uniquely positioned to provide. In New York, my current salary is at.
How did you get into community nursing, and what is your current role as an FNP in New York City?
I have always been interested in working in the public health, community health setting. I've spent a great deal with this particular organization in Memphis called Church Health, which is a nonprofit clinic that serves mostly underinsured and uninsured patients. While I was volunteering there, I got to know the population pretty well, which is mostly new immigrant from Latin America. Even though we are, from very different background, I really had a lot of fondness of their ways of life, their common struggles, immigrating to the United States, because I'm a first generation immigrant to the United States from Korea. I work currently at a federally qualified health center. It's a similar type of setting where I see a lot of patients from Latin America, especially nowadays, refugees who do not have any health insurance, do not have any basis in New York City. I see them at a discounted rate. Patients pay $15 flat for any type of visit.
Is that how a nurse practitioner get paid from an underinsured or uninsured patients?
Nurse practitioners are employed by that particular organization and paid hourly or salary wage. There are some private practices that offer revenue sharing, which is based on how much you collect from patient visits, those who have insurance versus who don't have insurance. For those who are able to pay self-pay rate, which is the amount that you pay without insurance. And then if you collect, let's say $100, you get to keep $50 from that revenue. I don't think there's any public sector that does revenue sharing.
I was wondering how the federally funded facilities, like where you're working, salaried nurse practitioners and nurses.
For my particular position, I get a base salary and then I have a productivity bonus, which is similar to revenue sharing. I get a set amount of extra money per extra patients I see.
What do you foresee your role as a nurse practitioner and a nurse in public health sector in the future?
I think there are a lot of possibilities. Traditionally speaking, nurse practitioners are formerly nurses, like a bedside nurses with RN, because nurses have such a wide range of jobs they can do. Nurses have already been pre-established in public health nursing, where they provide a lot of population health educations, outreaches. Nurse practitioners are uniquely positioned to provide both. Also, you can provide a provider level as a nurse practitioner, because nurse practitioners in the United States, especially in some states like New York, have full practice authority, which means that they are able to practice without a physician supervision after meeting 3,600 practice hours. Nurse practitioners are fairly approachable, versus doctors and physicians, and also be able to offer some of this complex medical public health information into more easily understandable pieces for patients.
They learn to practice nursing and medicine because they have to diagnose and prescribe. What position do you think nurse practitioners take compared to physician's assistants or physicians who base their practice in medicine?
The nursing-based care really comes through a lot of times in interpersonal interactions. So there are more nursing components that I try to bring in when I see patients. I try to look at what's going on around in their lives and make sure those are well addressed. Also address the current shift complaint or the illnesses they have. Actual medical care, it's mostly based on a physician's care model.
You're in the transition of switching to the U.S. Public Health Service Commission Corps. Could you tell about why you are interested in that sector?
The U.S. Public Health Services, the organization is a uniform service that provides a lot of public health, medical, and also in other public health science and engineering sectors to provide population health measures for United States citizens. There are a lot of opportunities for nurse practitioners to go into a clinical role and also transition into more public health, not as patient-facing role, but for a more population health-facing role to hopefully positively influence policies from local, state, and federal level. There aren't many clinicians who are writing this policy through public health services, and I'm able to get to a point where I am major stakeholder in publishing health policies, hopefully reach more people in the United States to better healthcare outcome.
What made you get interested in the community nursing in specific?
It's important to me that my work matters and it has a certain depth to it. How can I maximize my work into doing more good? Public health work will be the work that I can prove myself that my work will have meaning.
You are passionate about innovative care model. Could you tell us about how a nurse apply innovative care model into their practice?
With the COVID, telehealth really exploded. Virtual care has now become a mainstay for a lot of acute visits. Right now, we're only using it to address certain very limited numbers of complaints. Often we struggle with rural healthcare. With the virtual care, we'll be able to at least start to reach out. I really think US can benefit from universal healthcare, just like South Korea has. I am gathering different data and different researches how universal healthcare can come to be in the United States from the current privatized model. What kind of transition or efforts we need to make?
What do you think are some barriers in bringing the universal health insurance into the United States?
Typically, publicized big evils are the pharmaceutical companies, I think insurance companies, and now private hospitals, healthcare systems. With COVID, a lot of hospitals and clinics are being bought by private investing firms. Their primary focus is making money. They're compromising on so many patient care goals that patients suffer from it. They also kind of overly complicate those health insurance policies, how the claim works, how the coverage works for certain services. With medications too, you have to go through this prior authorization for allergy medicine.
Could you tell us what the prior authorization is for those who don't know?
It's the process that you have to deal with as a clinician in the United States. So when you send either medication or an imaging CT or MRI, anything that insurance companies needs to cover, those insurance companies will kind of kick back and say, oh, we need to have a look at this and then make sure that this is a necessary service.
And how long does it usually take, that back and forth conversation?
It can be done within 10 minutes on a good day. Sometimes you can get hold of them. It can take up to 24 hours.
You studied neuroscience for your bachelor. So what made that switch from neuroscience to nursing?
I was interested in neuroscience research because, brain, so fascinating. But I learned early on that research path is not for me. So I was on pre-med path, thinking more about how to go about becoming a physician in the United States with a student visa. I figured out that it's impossible. You have to have either a green card at least or a citizenship. 4 additional years of graduate training costs a lot of money. And as an immigrant, I couldn't afford that. That just doesn't seem to make any financial sense. So I was looking into other different paths in healthcare, and I came to learn more about nursing.
Nursing is saturated by females. What was it like to go into this female saturated industry as a person who didn't think nursing as an option in undergrad?
It's something that I thought about when I entered the program too. I wasn't too worried about it because from what I was told, I shadowed a bunch of nurses and nurse practitioners before I got applied to the program and got in, that they seem to welcome male nurses. Labor statistics show that male nurses, even though they're minority, they get paid more than female nurses. So unfortunately, that gender disparity still exists in the female-dominant profession. Even in the workspace too, I think there's that male privilege works wonders. For example, when I kind of make constructive criticism about my colleague or my medical assistant, it's pretty well received. If a female provider, a female physician, female nurse practitioner makes the same type of comment to their colleagues, it's not as well received. The male privilege is just really there, unfortunately.
I wanted to hear your perspective. When I was going into nursing, that was not even in my radar that nursing is saturated by females. I wanted to ask you how nurse practitioners are salaried in New York City.
It's high, definitely, compared to other parts of the United States. So, for example, I moved to New York from Tennessee, where Nashville, Tennessee, where I went to grad school and where I met my wife. In Nashville, Tennessee, a family nurse practitioner gets paid around, I believe, like $85 to $92,000 per year. Hourly can be a lot lower. I think around like maybe 38 to 40 something. In New York, my current salary is at $120,000 per year plus bonuses. So big disparity based on where you are. Nurse practitioners are overall underpaid. The reimbursement rate, collection rate, if the collection rate is good, reimbursement from health insurance companies, other programs are still the same wherever you go. New York looks high, but with the taxes and all that, it's still not as where it should be. Because there are so many people, a lot of patients, I typically average between 18 to 20 patients a day on an 8-hour day. A patient is scheduled into one 15-minute slot. And I do physical, sick visit, well-known woman visit, all that stuff. So I look at the coding, the complexity of the visit. You can kind of get an idea of how much the reimbursement will be from that patient visit. So let's say somebody comes in with like a flu-like symptom. There's a code for it, it's a 99913, which is about $90 reimbursement from insurance companies or self-pay. And then somebody who has like a chronic hypertension, diabetes, they also happen to have flu-like symptoms, then their complexity goes up and it's called 99914, and the reimbursement rate is about 160. On average, nurse practitioners, every patient that you see, you get around $100, and with 18 to 20 patients a day that you see for 5 days a week for a year, you can kind of estimate how much your salary should be. 120 is still below what you get paid.
Thank you for being transparent.
Yeah.
How did you move from Tennessee to New York? Was that because of a job?
Your first job is always hard to come by. So I was casting a wide net for a nurse practitioner job. And I also applied for a lot of jobs from the HRSA. HRSA is the organization that provides a lot of grants and scholarships for clinicians to work in underserved area. So like rural communities, urban, but marginalized communities. And they have a job fair with this federally qualified health centers. I went to apply to a bunch of them. And then when we moved to New York from Tennessee for my job in February 2020, we didn't know COVID was going to hit. Things shut down. They weren't able to bring me on for a few months. I worked at CVS Clinic for my first year. And then I went back to the current employer, the federally qualified health center.
What do you want to tell nurses and nurse practitioners who want to move to New York City and practice there?
I think it really depends on your lifestyle preferences too, because it's so expensive. You can barely afford a one-bedroom apartment or at around like $2,000 in Queens per month. And you have to pay upwards like $4,000 a month in Manhattan. If you value the experience, go for it. But if you're more financially conscious about like saving up for retirement, or saving up for a down payment for a house, I'll say New York is not the best place to do that.
I saw the housing in New York City has skyrocketed so much after COVID, like this year.
It's insane.
How do you invest your money?
So that's the topic that I really got into during COVID because, jobless, you have so much time at home. I got to learn about like different tax advantage accounts. So for example, health savings account, if you have a high deductible insurance plan, you're able to put $6,000 per year into HSA. And that account is triple tax advantage. You put pre-tax amount from your salary, and then you're able to use those pre-tax amount tax-free once you hit, I think, age 59 and older. And you can also use it before that for healthcare expenses. For healthcare and later on for retirement, you're able to use your pre-tax money without tax burden, unlike 401k. So 401k, you put pre-tax money now, and then you pay taxes later when you retire, right? So there's that still tax burden there. So we try to prioritize those tax advantage accounts. So HSA as much as we can when we can. Also try to put money into Roth IRA, which is after-tax retirement account where you pay tax now, but you don't get tax later. We put money into 401k, so pre-tax money from workplace, and also employers have matches, so they contribute a few $100s here and there. Thanks to my wife and my wife's family, we were able to purchase a co-op in Queens. So I guess real estate is a part of our investment portfolio. Future plan is to buy small rentals.
No, congratulations on getting your own home. That's a big step, especially in New York City. It's very stressful.
It was.
Since my audience is mostly Korean nurses who live in Korea who want to move to the US, what do you think they can do the first thing when they move here for investment?
It would be best to find a job that pays well. The financial literacy part is also very important. There was a big hurdle coming from like a Korean family who is not used to like investing. My parents went through the IMF in the 90s. So financial trauma is kind of passed on to more younger folks for our generation. And investment is such a mental hurdle to overcome. It took me a while to understand and feel comfortable putting money away. There's that uncertainty and then anxiety. Getting good financial literacy education, whether in Korea or in the United States, is going to be the big first step. What helped me was that there are also different financial plannings that you can do. Of course, you don't want to invest the money that you cannot afford to put away. So you want to have at least like 3 to 6 months of emergency fund where you can cover your fixed expenses like mortgage or rent, grocery, phone bills. Let's say like you get laid off, you get fired from a job. After kind of establishing that emergency fund, it really eased my anxiety into putting money away.
So that's why it's important that you only invest in what you can afford. Like you don't want to put your life away.
In the past 2 years, when there was like the crypto boom where, overnight millionaire, there's always this hype around some of those financial products that's as rare as winning a lottery ticket. Stick to tried and true dollar cost averaging, where like you're able to put a little bit of away each month to invest in, let's say like index funds, S&P 500s over a long period of time.
Because it's so shiny, like what we see in media, someone becoming from a zero to a millionaire with crypto. How much does the US lend for nurses, nurse practitioners when they buy homes?
It matters how much you make, so your salary, how much debt you have. So for example, like student loan, credit card debt, and banks will kind of run the numbers for debt to income ratio, kind of figure out if you're a safe lender. A lot of healthcare professionals get an upper leg because the healthcare jobs are so in demand all the time, unless you have a crazy credit card debt. And for nurse practitioners, some lenders will also provide this thing called physician loan. Banks consider physicians to be, of course, like high earner and then somewhat safe lenders because of the high earning potential. And they will offer pretty good terms for physicians, like 0% down. So you don't have to have any down payment to purchase like a $1 million house. In the United States, you have to pay this thing called PMI, some sort of a mortgage insurance, if you put down less than 20% of the purchase price as a down payment. And that can add up. Those physician loans, you can ask to waive the PMI for 0% down. Sometimes nurse practitioners and PAs also get those benefits from certain lenders.
Kiwan, how can the audience find you online?
LinkedIn messages are always welcome. LinkedIn works perfectly.